My father signed the consent form on a Tuesday. By Friday, he was gone. Not from cancer, not from heart disease, from a surgery his doctor called routine. He was 73 years old, and nobody in that hospital room warned us, not once, that his body might not survive the recovery, even if the surgery itself went perfectly. That distinction between surviving an operation and surviving what comes after it took me 22 years in medicine to fully understand. And today, I'm going to make sure you understand it in the next 15 minutes. My name is Dr. Kevin Adewale. I spent 2 decades as a geriatric medicine specialist, which means I was not the doctor who held the scalpel. I was the doctor called in afterward. I was the one standing beside the bed when a 78-year-old woman couldn't remember her daughter's name 3 weeks after a successful knee replacement. I was the one explaining to a family why their father, sharp, funny, independent, was suddenly confused, incontinent, and needed round-the-clock care following a surgery his orthopedic surgeon had rated as low risk. I have watched patients walk into hospitals with problems and leave with entirely different, sometimes far worse ones. And the surgeries I'm about to describe are not rare, botched procedures. These are common. These are performed every single day across hospitals in every city. Some of them might even be on someone's calendar in your family right now. So before I start, I want to be honest with you about something. I am not anti-surgery. Surgery is one of the most extraordinary things human beings have ever invented. I have seen it reverse blindness, restore movement, and add decades to lives. What I am against is uninformed consent. What I am against is a system that too often presents surgery as a destination when it should be presented as one road among several. And for people over 65, the choice of road matters more than almost any other medical decision you will ever make. Let's start with the first one. There is a surgery performed on hundreds of thousands of older adults every year that most patients agree to because their doctor explains it using the simplest possible logic. Your spine is compressing a nerve. We go in, remove the pressure, and the pain stops. That logic sounds airtight. The problem is it leaves out what happens to a 70-year-old body when you cut through layers of muscle, rearrange vertebrae, install metal hardware, and ask a spine that has been moving a certain way for 7 decades to suddenly accept a rigid, fused structure. Lumbar spinal fusion in elderly patients carries one of the most quietly dangerous risk profiles in all of elective surgery. Here is something I want you to sit with for a moment. A comprehensive review published in the journal Neurosurgery found that in patients over 65 undergoing multi-level spinal fusion, the rate of a major complication called a dural tear, where the protective membrane around the spinal cord is accidentally punctured, approached 20%. 20% in 1 in 5 cases, and that is one complication. The full list includes hardware loosening, nerve damage, blood clots, surgical site infections, and a phenomenon called flatback syndrome, where the surgery permanently alters spinal alignment and creates a new chronic pain condition where none existed before in that particular form. Patients come in with back pain. Some leave with back pain plus. Now here is the part that genuinely unsettles me. Research from Dartmouth consistently shows that in regions where spinal surgeons are more densely concentrated, spinal fusion rates are dramatically higher, not because patients in those regions have worse spines, but because surgeons with a tool tend to reach for it. If you have been told you need spinal fusion for chronic back pain, and you have not yet had a formal trial of supervised physical therapy, targeted epidural steroid injections, and a pain management specialist evaluation, you have not yet exhausted your options. That is not my opinion. That is the position of the American College of Physicians. Ask your spine surgeon this before you sign anything. Can you show me peer-reviewed evidence that, for my specific diagnosis, surgery produces better outcomes at 2 years than conservative management? That question alone will tell you everything about the surgeon you are sitting across from. Have you or someone you love been told fusion was the only path? Tell me in the comments. I want to know how often people are hearing that. The second surgery on this list affects a part of the body that seniors are told to worry about constantly, and yet the surgery designed to fix it is discussed with far less caution than it deserves. The gallbladder. Gallstone disease is extraordinarily common in people over 65, and the standard treatment recommendation, once gallstones become symptomatic, is laparoscopic cholecystectomy, removal of the gallbladder. For a 50-year-old in good health, this is genuinely one of the safer abdominal surgeries available. For a 75-year-old with diabetes, reduced kidney function, and any degree of frailty, the calculus shifts dramatically, and most patients are never told how dramatically. What happens without a gallbladder is the beginning of a problem nobody discusses in the pre-surgery consultation. The gallbladder is a bile reservoir. Remove it, and bile drips continuously from the liver directly into the small intestine, regardless of whether you have eaten. For younger patients, the gut adapts over time. For elderly patients with already compromised digestive motility, this continuous bile drip triggers a condition called post-cholecystectomy syndrome in a substantial proportion of cases. Chronic diarrhea, bloating, indigestion, and bile acid malabsorption that can persist for years or permanently. Somewhere between 10 and 40% of patients experience this. The range is that wide because it is genuinely understudied, and more tellingly, because patients are rarely told to report these symptoms back to their surgeon. Beyond digestion, the surgical risk itself in frail elderly patients includes anesthesia complications, bile duct injury, which can be life-threatening, and post-operative pneumonia from the carbon dioxide gas used to inflate the abdomen during laparoscopic procedures, which can cause referred shoulder pain and breathing complications in patients with any pre-existing pulmonary compromise. What is the alternative worth discussing? Ursodeoxycholic acid therapy can dissolve certain types of cholesterol gallstones over time. Dietary management can significantly reduce symptom frequency. For patients whose gallstones are asymptomatic or minimally symptomatic, watchful waiting is a legitimate evidence-based strategy, particularly when the risks of surgery for that patient's specific health profile are high. The conversation your doctor should be having with you is not, "Do you want surgery or not?" It should be, "Given your complete health picture, what does your personal risk-to-benefit ratio actually look like?" I need you to hear the third one very clearly because it involves a decision millions of families face every year, and the emotional weight of it makes clear thinking almost impossible in the moment. When someone you love is diagnosed with cancer and a surgeon says we need to operate, the word no feels like a death sentence. It is not. Sometimes, for elderly patients in certain conditions, that no is the most life-preserving answer available. Major colorectal cancer surgery in frail elderly patients, hemicolectomy, anterior resection, abdominoperineal resection, carries what researchers call a failure to rescue rate that should be part of every pre-surgical conversation and almost never is. Failure to rescue means a complication develops post-operatively that the patient's body cannot mount a sufficient response to survive. A study in the Annals of Surgery found that in patients over 75 undergoing emergency colorectal surgery, mortality rates in some subgroups exceeded 40%. Even in elective cases with frail patients, the 30-day mortality in high-risk groups runs between 15 and 25%. Here's the question that changes everything. What does the oncology evidence say about non-surgical management for your specific cancer, stage, and health profile? In early-stage colon cancer in elderly patients, endoscopic mucosal resection, a far less invasive technique, now achieves complete resection in many cases without any abdominal incision. Palliative chemotherapy and radiation, when surgery is genuinely too risky, can manage symptoms and extend quality of life in ways that were not possible a generation ago. The goal of cancer treatment is not the removal of a tumor. The goal is more good time. And for a frail 80-year-old, aggressive surgery that leads to a 6-week ICU stay, a permanent colostomy, and death from sepsis 4 months later did not achieve that goal, regardless of what the pathology report said. I want you to ask your oncologist one specific question if major cancer surgery is recommended. What would happen to someone with my exact health profile, my frailty score, my comorbidities, if we chose the most aggressive non-surgical option available right now? If the answer is a pause, a deflection, or an implication that only surgery is real treatment, you need a second opinion from a geriatric oncologist before you proceed. The fourth surgery on this list is one most people consider a triumph of modern medicine, and it genuinely is, for the right patient. Total hip or knee replacement has transformed the lives of millions of people. I have seen patients go from barely managing stairs to hiking with their grandchildren. The surgery, when it works, is remarkable. But here is what the orthopedic brochure does not include. For patients over 75 with 3 or more significant comorbidities, heart failure, type 2 diabetes, chronic obstructive pulmonary disease, chronic kidney disease, elective joint replacement carries a cluster of post-operative risks that can cascade faster than the medical team can intervene. Deep vein thrombosis, pulmonary embolism, post-operative delirium, which in elderly patients is not simply temporary confusion, but a major risk factor for long-term cognitive decline, loss of independence, and death within 12 months in vulnerable populations. Hospital-acquired pneumonia from reduced mobility. Surgical site infection, which in diabetic patients with compromised circulation can reach bone and require amputation. Here is what I find most troubling. I have sat in preoperative clinics with patients who were told their primary preparation for surgery was to stop aspirin 2 weeks before the procedure. That is it. No formal assessment of frailty, no cardiovascular optimization program, no nutritional evaluation, no exercise prehabilitation. The fifth surgery is the one that frightens me most to discuss because, unlike the others, you cannot schedule your way around it. Emergency vascular surgery, specifically repair of a ruptured abdominal aortic aneurysm, carries extremely high mortality. A ruptured abdominal aortic aneurysm carries a mortality rate in patients over 75 of between 50 and 70%, even with immediate surgical intervention. What nobody discusses is this. Sometimes the most appropriate option is comfort-focused palliative care. So here is what all 5 of these surgeries have in common. They are not wrong, but they are often presented without full context. Before any major surgery, ask 4 questions. What happens if I do nothing? Are there less invasive options? What does recovery look like for someone like me? What are your complication rates in patients like me? Those questions can change everything. There is almost always another door. Make sure you see it before you choose.